The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
Thank you very much for that introduction. I appreciate it. Again, my name is Ryan Schulte. I practice at Urology Center of Iowa here in Des Moines, Iowa. And just a kind of brief overview of what we're going to talk about today. First, I'll kind of just talk about the prostate, what it is, why it's important to know about it. Next, we'll kind of go over what BPH is. As urologists, and doctors say the terms BPH all the time. What do those letters mean and why is that important to you? And lastly, and probably most important, we'll talk about treatment options, like what can you do for BPH and more specifically the urinary symptoms from BPH. So again, what is the prostate? So this picture on the right here, this is a cross-sectional view of the male pelvis. So on top there's the bladder. That's what stores the urine. The bladder is a muscle. Right underneath that's where the prostate's at. So when your doctor does a prostate exam, which is a rectal exam, you can see the rectum's right behind the prostate, and that's why they're doing a prostate exam, because they can feel the prostate through the rectum. It's about a walnut-sized gland, sits right at the base of the bladder. Also, you can see what's called the urethra, or the urinary tube, goes right through the middle of the prostate. And so that's relevant. We'll talk about it more as you age, as the prostate enlarges. It can squeeze on that urinary tube and cause some symptoms. And so normally the prostate will grow to about a normal adult size by the time the man's in his 20s. And then as the man ages, kind of by his mid-40s, it can start to grow again. And that's when we may see some of those symptoms again. And what I tell patients is that when you're younger, the prostate is important for reproduction. It can transport some sperm. As you get older, really the only thing it does is causes urinary problems and can get cancer. It has no vital function in older gentlemen, like a kidney or a liver or anything like that, but it can cause quite a bit of urinary issues, which we'll talk about more in detail. So different things can happen to the prostate. Today we're going to focus on BPH, which is enlargement of the prostate, but there's other symptoms and syndromes that can look like BPH. On the left is kind of what a normal bladder and prostate should look like. Going over to the right, prostatitis, that just basically means infection or inflammation of the prostate. It can have symptoms similar to BPH, a lot of urgency of urination, frequency of urination, a little burning with urination, but most of the times the symptoms are limited and will resolve either on their own or maybe with some antibiotics. BPH will go much more in detail throughout this talk. And then prostate cancer usually is caught early and doesn't really cause a whole lot of urinary symptoms. If it does cause a lot of urinary symptoms, sometimes it can be a little more advanced, but today we're going to focus specifically on BPH. So again, what is BPH? What do those initials mean? So again, BPH, B stands for benign, which means non-cancerous. P stands for prostatic, which is relating to the prostate gland. And H stands for hyperplasia, which just means there's more cells than normal. In normal layman's terms, when a doctor says BPH or you hear BPH, what it means is just enlarged prostate. It's grown to a size that's larger than normal. A normal adult size is, again, about the size of a walnut, 1.5 inches in diameter. And as it grows, mid-40s and beyond, as it grows, it can lead to some constriction of that urinary stream, which in turn can lead to some lower urinary tract symptoms, which we'll talk about more in detail. So one thing patients always ask, anytime we talk about treatment for enlarged prostate, they always ask, oh, is it cancer? Can it be cancer? So I just want to clarify a few things. BPH, again, is benign, prostatic hyperplasia, so benign means non-cancer. So BPH is not prostate cancer. BPH does not cause prostate cancer. It's not a precancerous position or precancerous condition. BPH symptoms can sometimes be similar to those of cancer. As I mentioned earlier, most prostate cancers nowadays are caught pretty early and don't cause much in the way of symptoms, but sometimes advanced prostate cancer can cause some BPH-like symptoms. BPH can coexist with prostate cancer. And then PSA, which stands for prostate-specific antigen, is a blood test that your doctor or urologist will frequently check. And what the things I tell patients is that PSA, again, stands for prostate-specific, I should say specific antigen there, which is specific to the prostate and not specific to cancer. So both BPH and prostate cancer can cause elevated PSA. And so that's why, we go to the doctor, and when the doctor can determine which of those it may be contributing to it. Of all the slides in this presentation, this is probably my favorite, and this is probably the one, it's simple, but it's the one that I probably use with patients the most to kind of explain what an enlarged prostate is, how it causes problems, and why it's a problem. Because if you can understand why it's a problem, then you can understand why the things we do to treat it may or may not work. So again, on the top of the screen is the bladder. That is a muscle. When you urinate, that bladder muscle contracts and the urine comes through, following those green arrows, through the urethra and then out the end of the penis when you urinate. Right below the bladder, again, is the prostate, that kind of walnut-sized organ right at the base of the prostate, and you can see the urethra goes right through the prostate. On the left side is the normal one, nice open channel. On the right side is an enlarged prostate. You can see as the prostate enlarges, it starts to squeeze down on that urinary channel, that urethra. What happens when it squeezes down? You start to experience some weak stream, decreased force of stream, a little hard time starting your urination. Because it's obstructed, you may not empty your bladder completely. As you can see, the bladder is about the same size, but if you imagine on the right side, if you go to the bathroom at 10 p.m., let's say, and if you empty your bladder completely, it may be, 6-8 hours before you have to get up to go to the bathroom. But if you are only emptying your bladder out part way, it's going to be about half that time before you have to urinate. So hence the reason why you're having frequent urination in the evening, and also that'll lead to more frequent urination in the morning or during the day. Again, as the prostate is obstructed, that bladder's a muscle. What happens? That bladder muscle starts to squeeze harder to try to overcome that blockage. As it squeezes harder, that bladder muscle becomes more thickened. As it becomes more thickened, it becomes more irritable. As it becomes more irritable, that can lead to urgent urination where, I got to get to the bathroom right away. I don't have enough time. And then as it progresses, this can lead, and all those things I just talked about are they're bothersome, but they're not real serious problems. They're just bothersome quality of life problems. As it progresses, it can potentially cause some more serious issues. If you have urine that's just retained in the bladder, you're at increased risk for bacteria forming and urinary tract infections forming. You're at increased risk for forming bladder stones. And what I tell patients is that bladder muscle, it's kind of like a rubber band or a sock. When it's new, it's got a nice, good spring back. But over time, as it gets stretched out, it loses its kind of snap back. And the bladder can compensate to a certain point, but if it's left untreated for years and years and years, sometimes it can just give out. And obviously, we want to intervene with patients before that, because otherwise you're that smiling face on the urinary catheter commercial, which nobody's really a smiling face on a urinary catheter commercial. So you never want to be that. So again, I explained how these symptoms appear. So just quickly to review, oftentimes they'll start with a weak urine flow, trouble starting and stopping the urine flow. After urination, you'll have that sensation your bladder's not empty, which leads to frequent urination during the day and night, which may lead to a sudden urge to urinate. And then again, the more advanced symptoms may be risk of urinary tract infection, risk of bladder stones. You can't pee at all, which would require a catheter to be placed, and a risk of bladder dysfunction, which means the bladder's not working like it should, which may be permanent. And so if we're going to intervene or treat for BPH, we want to get you and treat you, when you're in the top half of those symptoms, which we can do something to improve those symptoms and have long-term improvement. Because if it gets all the way to the bottom where there's some permanent bladder dysfunction, it may be too late to make a meaningful impact. You can still do something, but the impact won't be as good as if earlier intervention had been sought. What we're talking about, again, it's not prostate cancer, it's not life and death, but I tell patients it can have a significant effect on quality of life. Men sometimes aren't the best at going to the doctor. Sometimes they put it off and say, I can live with this. But there's a difference between I can live with this and is this a good way of living? So 95% of men with moderate symptoms are unhappy and don't want to spend the rest of their lives with these symptoms. Oftentimes, they'll experience some sexual problems with them. And 51% of patients will say it will interfere with an aspect of their normal life. And it's not just the patient's quality of life. Oftentimes, it's their partner's quality of life. If you're going on a road trip and you have to know where every rest stop is, every hour you're having to stop, or, some guys, I got to pull up on a gravel road. I have to have an emergency cup in my van. If you're going to a show and you're like, ooh, can I make it to intermission, or can I make it through this movie? If you're getting up frequently at nighttime and you're waking your partner up, again, it can affect both patients' quality of life. And, it's very rare that someone's going to die from something related to BPH, but again, it can have a significant effect of quality of life. And the majority of patients with BPH aren't seeking out medical attention. They just say, oh, it's just part of getting old. I can live with this. But there are things that can be done to improve your quality of life so you don't have to live with it. Who can get BPH? Oh, very, very common. So it's the most common prostate problem for men over the age of 50. Over the age of 60, over half of men will have symptoms of BPH. If you live long enough, you're going to get BPH type urinary symptoms. 90% of men are affected by the age of 85. Over 14 million men in the US are having some sort of lower urinary tract symptoms. And again, there is a large percentage of these men who aren't seeking out treatment because, again, they just figure it's just part of aging. So how is an enlarged prostate diagnosed? So most of the times, someone comes to the urologist or the doctor. The first thing the way we diagnose this is just by taking a medical history. You tell us about your urinary symptoms. Oftentimes, we have you fill out a questionnaire. On the right side, one of the most common ones is the International Prostate Symptom Score. It asks you a series of questions about your urinary symptoms. And I'll look at that. I'll see what kind of symptoms you're having. And then what I'll do, oftentimes I'll ask to tell the patient, tell me the one or two most bothersome symptoms that you have. Most of the times, men over the age of 50, if they're having urinary symptoms, oftentimes it's almost always enlarged prostate. And then we'll do a physical exam. We'll do a prostate exam to get a general sense of the size of the prostate. Make sure we don't feel any hard nodules or suspicious lesions that are suspicious for prostate cancer. Often we'll check a PSA blood test. Again, that's a screening test for prostate cancer. You rule out any worrisome causes. And then oftentimes we'll do some testing to see how well you empty your bladder and what kind of flow you can produce. And so a little ultrasound on the bladder to see, again, if you're retaining any of that urine. And then sometimes a little test to see what kind of flow you can produce. Nowadays, they even have an app on your phone that you can just put on the counter. You turn it on the microphone, you pee in the toilet, and it can tell you what kind of flow it produces. And then oftentimes, we may do some other tests to kind of see how big the prostate is, how much blockage it's causing. What I tell patients is at first, I want to make sure it's nothing worrisome. We're going to rule out prostate cancer. Second, we want to get to the bottom of what's causing your urinary symptoms. We assume it's due to enlarged prostate most times, but there are other forms of urinary symptoms that can present. And third, we want to come up with a good treatment plan to improve your urinary quality of life. Most importantly, I want to kind of express what are some things that we can do to help with urinary symptoms related to BPH. So this is a spectrum. So on the left side of the spectrum, the less invasive options. On the right side of the spectrum is the more invasive options. from all the way from just, watchful waiting, changing some diets, changing your fluid intakes to kind of some medications, some, minimally invasive office procedures, all the way to removing most of the prostate through a surgery. And there's not a one size fits all. It's not everything doesn't apply to every single patient. And so that's why I tell the patients, I want to find what's going to be best for you. And I tell patients, I want to find the least invasive, most effective option. I don't want to do a procedure, even if it's going to be effective, if it's overly invasive. And I don't want to do a minimally invasive option if it's not going to be effective. So our goal is to find the most effective, least invasive option to improve patients' urinary quality of life. So watchful waiting. So just like it sounds, you're just kind of watching things and you're waiting. This is, used for very mild symptoms. I don't see many of these patients because if they're coming to the urologist, most of the times they are already beyond this stage. But what are some general things I tell every patient, even if they're coming to me and they're on medications, they're interested in a procedure? What do I tell them? I tell them, let's cut down the caffeine, cut down on the coffee, soda. Caffeine's a strong bladder irritant. That's going to make your frequency and your urgency worse. Watch your fluid intake after dinner. It should be obvious, but not everyone kind of puts together, hey, if I drink more fluid, I'm going to pee more. So if you have a big glass of water or milk or beer or wine right before bedtime, that's just a recipe for having to get up at nighttime. And then there are also, although I don't have a separate slide for this, between watchful waiting and medications, there's supplements. Saw palmetto is the most common one used in BPH. And the studies are kind of mixed. There's some studies that show some improvement. There's some studies that show not much change. And I'm not necessarily for them or against them, but I tell patients is that if you want to try them, that's fine. If you feel like they work, I'm okay with you continuing them. There's going to be a placebo effect initially, but if you feel like there's a persistent improvement, that's fine. If not, you don't need to keep spending your money on something if it's not improving things. And this is part of that population I was talking about where patients don't seek medical attention. We see something commercial late at night that's advertising some supplement. We're in this age of like where we used to, clicking something on Amazon Prime, get it on our doorstep 2 days later, and we're just used to, hey, I want something quick and see if it will work. Again, if it works, great. If not, what are some other options we can try? So next I'm going to talk about medications. There's 3 main classes of medications for enlarged prostate. Probably the most common one is called alpha blockers, Flomax and tamsulosin. That's the most common medication used for enlarged prostate. Tamsulosin is a medication that's available through menMD, and tamsulosin is a medication that when it's first started is usually pretty effective. When patients first started, I feel like they usually get a pretty good response. There are potential side effects. It sometimes can affect the blood pressure, it can cause a little lightheadedness or dizziness, what's called retrograde ejaculation or decreased fluid in the ejaculate. But by and large, I feel like patients have a good response when they first start this. It's not necessarily the best long-term option, but I think it's probably the most common medication that I use. And by the time they see me, most of the times they're already on it and they're coming to see me, because it's no longer working. Another class of medication is called the 5-alpha reductase inhibitors. Finasteride is the most common one of this, again, and also available through menMD. Finasteride, the way it works is that it decreases the production of DHT, which is a male sex hormone, which in turn shrinks the prostate. By shrinking the prostate, the goal is to improve the urinary symptoms. It can take 3 to 4 months to see improvement and about 2 years for maximal improvement. It can potentially cause some erectile side effects or lowered sex drive. So I'm a little hesitant to use it in the younger patient population. I will sometimes use it in men that are 80 and older and aren't overly concerned about erectile issues, but in younger gentlemen, I tend to hold off on it. And the last class of medications I'll talk about are called phosphodiesterase inhibitors. These are the generic Cialis, the generic Viagra. Obviously, we all know that they're used for erectile dysfunction, but they also can be used for BPH. They relax the smooth muscle in the bladder and again help ease the urinary symptoms of BPH. Similar potential side effects could be some headache or flushing. Oftentimes I'll use this if patient has some mild BPH symptoms as well as some mild erectile dysfunction symptoms that can kind of cause almost a 2-for-1 effect. And so those are the 3 main classes of medications. Next, I'll kind of move on to what are some minimally invasive options that we can consider when medications aren't working. When do we consider moving beyond medications? It's if 1, medications aren't working, 2, medications are producing side effects, or 3, patients just don't want to be on medications the rest of their lives, or 4, if we're worried about medication interaction with other medications. And so the medications, they can relieve the symptoms, but they're not getting to the root cause of the problem. They're lifetime medications. When you start them, they're going to help with your symptoms while you're on it, but when you stop it, your symptoms will come back because it's not necessarily treating the root cause, it's just helping the symptoms. It's kind of like a Band-Aid. It'll help, and it usually will last for a few years, but long-term may not be the best option. So when any of those 4 times occur, there are some other options. Resume water vapor therapy is one of those options. It's a non-surgical in-office procedure which uses steam or water vapor to treat the prostate. A small scope is inserted into the bladder, and then the 2 sides of the prostate are treated with that steam or water vapor, which causes it to shrink down. It provides some good long-lasting improvement, and doesn't affect erectile issues, and usually you can return to regular activities in a few days to a week. So on the next slide, we'll show just a short little video of how the Resume water vapor therapy works. So again, here's the prostate, the urethra. A scope goes in there. 2 sides of the prostate were treated with water vapor. Each of these treatments takes only 9 seconds. So this guy had 4 treatments, a total of 36 seconds of treatment. And then with time, it causes the prostate to shrink down. It's a process that takes time. I usually tell patients 1 month, 2 months, 3 months, you'll continue to see improvement. And so what I tell patients after any of these treatments, there's what's called Resume water vapor therapy. There's something called UroLift. They each take about 5 minutes. They're done in the office with a little nitrous oxide or laughing gas and some numbing medicine. Doesn't require generally anesthesia. There is some irritation afterwards. So the line I always tell patients is that 3 days after the procedure, you may be saying, why did I do this? Because it's irritated. Your urgency and frequency is a little worse because of some swelling. 3 months after the procedure, I tell them they're going to say, why didn't I do this earlier? By and large, we have a great response. 97% of patients would recommend Resume to a friend. And at 4 years, only 4.5% of patients are going to need some additional treatment. So over 95% of patients don't need any additional treatment. And so it's a good minimally invasive option for those patients who maybe medication long-term is not a great option for them, or if patients just don't want to be on medication long-term. There's also what's called prostatic urethral lift, also known as UroLift. And so as opposed to the Resume procedure, which uses steam to shrink down the prostate, UroLift or prostatic urethral lift just displaces the tissue. So small little implants are placed. And I tell patients I use the analogy of it's opening the curtains, so to say, opening the curtains to make that flow to kind of help ease the urine flow. Again, right afterwards, it's going to cause some irritation with urination, blood in the urine. That does not require general anesthesia. Again, takes about 5 minutes and done in the office with a little nitrous oxide and numbing medicine. There are some implants that are left in place. A little bit higher retreatment rate. 13% will need additional treatment at 5 years, but still close to 90% don't need any additional treatment at 5 years. For the bigger prostates, there's what's called green light laser therapy. So the Resume procedure, the UroLift, those are what we call minimally invasive surgical treatments. Those are in-office therapies. Those are best for prostates that are in the range of 30 to 80 grams. So a normal walnut-sized prostate is 25 grams. So imagine that 30 to 80 grams, that's what's best for those. For a big prostate, 100 grams and larger, green light laser is going to actually remove tissue and work better for these really big prostates. It does require general anesthesia. It's done on an outpatient basis, a little bit longer recovery or irritation, but is still a very good option for those patients with the enlarged prostate. Transurethral resection of the prostate, also known as TURP. This is kind of what some of the older gentlemen will call the rotor-rooter or ream job. It's not a very attractive description, but I guess that kind of gets the point across. I rarely do these anymore. I do some mission work in Kenya, so I get lots of experience with my TURPs over there because they don't have access to the other technologies. It still works. It's just a little bit more invasive than need to be for most patients nowadays. And prostatectomy is when you actually do surgery through incisions to remove a large portion of the prostate. Again, the only time I ever do this is in Kenya, where we don't have any other options. You can do robotic prostatectomies for really big prostates, but most of the time prostatectomy is more invasive than it needs to be nowadays. This is just a general disclaimer slide that says make sure to check with your insurance company for coverage for these. These are all been around for a while. It's not an issue, but we always have to say that. So here's a summary. So what did we go through? We talked about the prostate. What is the prostate? It's that gland that sits at the base of the bladder. As you age, it enlarges. As it enlarges, it squeezes on that urinary tube. As it squeezes on that urinary tube, it can cause urinary symptoms. And those urinary symptoms can continue to cause bothersome problems. It's not a life and death issue, but it causes quality of life. So when we say BPH, that's just a fancy term for enlarged prostate. So we went over treatment options. We talked about watchful waiting. We talked about some changes in your diet and fluid intake. We talked about first-line medical therapies, 3 different classes of medications, minimally invasive office procedures such as Resume or Urolift that are quick office procedures that may take the place of medications. And for the really big prostates, we talked about more invasive procedures. So I think my take-home point is there's not a one-size-fits-all. So that's why it's important to see your doctor, to see your urologist, to kind of determine what's best for you. Don't just live with it, just because, oh, it's not that bad, I can live with it. We can do things to improve your quality of life, whether that's, medication or procedure. And I'll just end with a quick, I was in clinic today. I saw a lot of patients with enlarged prostate or BPH. One gentleman is doing just fine, has been on medications for about a year. Symptoms are mild, we're just going to continue his medication. One gentleman, I did a Resume procedure about a year ago. He's very happy and is glad he did it and not taking any medications. Another gentleman, he's been on medications for many, many years, just kind of tinkering along on them, and now he has urge incontinence. And there's probably some things we can do, but it's not going to respond as well because he kind of waited too long, and now he's got some permanent bladder dysfunction. And the last gentleman, I've been telling him we need to be doing something for years, and he's kind of like, I'm fine. And unfortunately, I saw him because he was in the hospital. He has a catheter, and he's been having recurrent UTIs. And so in that whole spectrum, some were fine with medications. One had a minimally invasive procedure. One should have had some procedure, but it just decided to live with it. And so again, my point is, it's not a one size fits all. Talk with your doctor. Let's get to the bottom of why you're having problems and what can we do to improve your urinary quality of life, secondary to the BPH. So I'll stop with that. I'll turn it back over to Ashton, and if there's any questions that pop up, I'd be happy to answer anything.
Awesome. Alrighty. Just before we hop into the Q&A, we'd like to thank Boston Scientific for sponsoring this event. They are one of our best partners. So continuing on, we have our Q&A section here. I'm going to start us off right now by asking some general BPH questions. The first one we have here is, how can one distinguish between BPH and overactive bladder regarding urinary frequency and urgency?
Usually it's a spectrum that in men, it's a little bit of both. And so strictly BPH early on oftentimes is, decreased stream, hard to get it started, some urinary frequency because of incomplete emptying. And then, as I talked about, if it goes on for a long time, it goes on for years, you can get some bladder dysfunction. That's when you start to see some of that frequency and urgency that leads to overactive bladder. You can also have just overactive bladder on your own, which is very common in women, maybe a little less common in men, just plain overactive bladder. Those are the times decrease your caffeine intake and those things. But again, as we start with enlarged prostate, and then when it goes untreated, you can have some overactive bladder with it. We almost want to intervene before it gets to the overactive bladder stage, because once it gets to the overactive bladder stage, I can do something to relieve the blockage from the prostate. But if there's permanent bladder dysfunction, hey, your stream's going to be better, your emptying's going to be better. You probably won't get up as much at night because you're emptying better, but you still may have some of those urgency and frequency because you've undergone some permanent changes in the bladder. So our goal is not only improve your urinary quality of life, we want to preserve your bladder health. We want to make sure that your bladder stays healthy for a long time and not just, hey, once I've been on medications for 15 years and then just I'm peeing my pants, then I'll go do something. It's not as effective that. So the short answer is there's usually kind of often a connection or inter relationship between both.
Alrighty, and follow up to that, which is going to reiterate some information from the slideshow, but can an enlarged prostate cause either or both of these conditions, referring to BPH and overactive bladder?
Yeah, absolutely. So not everyone with an enlarged prostate has urinary symptoms, and not everyone with urinary symptoms have an enlarged prostate. But in general, the larger the prostate, oftentimes you'll see more urinary symptoms. Enlarged prostate, I guess I kind of explained that before. It will start with some of the urinary symptoms, and then can lead to some overactive bladder type symptoms as well. Most of the time, I tell patients it starts as a prostate problem, and then can become a prostate and a bladder problem. And again, we want to do something before it becomes a prostate and bladder problem, because you don't respond as well to treatments when it gets to that point.
Alrighty. Next question here. This person is asking what they should do if they have female estrogen levels, even under, excuse my pronunciation of this drug, but dutasteride, I believe is how you say it. And yeah, they're wondering what they should do.
Repeat that one more time, Ashton.
So apparently they're taking, is this correct?
Dutasteride is like finasteride, yep.
Dutasteride is the drug that they are taking, and they have female estrogen levels under this drug.
Okay. Yeah. So what happens? 5-alpha reductase inhibitors such as finasteride and dutasteride, they decrease the conversion of testosterone to dihydrotestosterone. One of the side effects of that is it's rare, but I haven't seen it in a long time, is gynecomastia, which is male breast growth. Obviously, nobody likes that. That can be due sometimes to some of the estrogen levels. Again, that's one of the reasons I'm not a huge fan of long-term finasteride use. I will use it in some patients, and we'll just kind of monitor things closely. And it's okay for those big prostates that we're going to use maybe in a shorter period of time. But I have some patients who are on it longer term. But we just have to be careful and watch for some, potential side effects.
Alrighty. So the next question here, what are the anatomic and clinical symptoms and signs of an enlarged prostate? Again, another review, but just to cover that.
So again, the most common signs and symptoms are urinary issues. As it squeezes that urinary tube, again, you're going to see decreased urinary stream, incomplete emptying. You're going to see, hard getting it started. In turn, can kind of become urinary frequency, getting up more at night. Some of the urgency may occur. If it gets really bad, you get to the point where you can't pee at all and you need a catheter. You may see some urinary tract infections. I live in Iowa. There's a lot of small farm ponds in Iowa, and the analogy I give patients is that if you've got a little river or stream flowing through, not much stuff overgrows in that because it's constantly moving water. Your bladder's that same way. If you're emptying, you're moving water through, bacteria is not going to grow. Those little farm ponds in Iowa that are sit stagnant, they get overgrown with algae every summer. So your bladder is the same way. If you got this stagnant urine that's just sitting in the bottom of your bladder, it's more conducive for bacterial growth. It's more conducive for bladder stone growth. And so what we want to do, we don't want urine to just sit stagnant in the bottom of the bladder. We want urine to flow into the bladder. And then when you decide to urinate, we want it to flow completely out of the bladder. And so those are kind of the more end stage problems of infection and stones. But if it gets to that point, we've missed a little bit of window of opportunity.
Alrighty. Next question here. How can BPH cause difficulty with ejaculation?
So BPH and erectile dysfunction are often seen together. It's not that one necessarily causes the other, but oftentimes they'll be seen in conjunction. Hence the reason that we'll sometimes use tadalafil or generic Cialis because it can treat the BPH and the ED. As the prostate enlarges, again, those ejaculatory ducts come right through the prostate. And so if there's a prostate enlargement, if there's prostatitis, infection, or inflammation of the prostate, it can affect, ejaculatory volume. May see some blood in the semen, just because those ejaculatory ducts come right through the prostate. Hence the reason when someone's on tamsulosin or Flomax, they can have what's called retrograde ejaculation, where it relaxes that smooth muscle. Again, it doesn't affect erections, it doesn't affect sensation, it doesn't affect the ability to reach orgasm or climax. It's just that when you reach that point, there will be decreased fluid that comes out. So that's common with tamsulosin, one of the medications used. It's seen pretty much all the time in like the more invasive procedures, like the TURP, will also be seen in the green light, can be spared in UroLift and Rezum, which is appealing for some patients.
Alrighty. Next question here. Can BPH cause a burning type of pain in the perineal area?
So that is more consistent with prostatitis. And so, in the beginning of the talk, we talked about different things that can affect the prostate. So burning in the perineum area. The perineum is that area between the scrotum and the rectum. That's kind of where the prostate sits. And so if someone has infection or inflammation of the prostate, that is where you often will see burning or inflammation. Usually just strictly benign enlargement of the prostate is not going to cause burning. It's going to cause those urinary symptoms, but typically not burning of the perineum. Usually that's due to inflammation and or infection of the prostate from prostatitis, which can be treated with antibiotics or anti-inflammatories.
Alrighty. Next question here. With no bothering symptoms, could unattended BPH still be dangerous?
Well, I tell patients an enlarged prostate in and of itself is not a problem, but an enlarged prostate that causes urinary symptoms can be a problem. So if someone, their doctor does a routine regular prostate exam and says, oh, you have an enlarged prostate, or someone gets a CT scan for something else and it says enlarged prostate. If they are having no symptoms at all, that's okay. We don't need to necessarily, do a medication or a procedure just because their prostate's enlarged. But I tell those patients I would have a lower threshold for considering, starting a medication or an intervention, and just keep that in the back of your mind. I'm not, if you tell me I don't have any symptoms at all, I urinate just fine. Most of the times we don't need to do something right away. But, thinking towards the future, hey, keep that in mind. And if you start to have symptoms, let me know. But just an enlarged prostate by and of itself is not necessarily a means that everybody needs to have some sort of treatment. It's symptoms with an enlarged prostate. Some are worse than others.
Alrighty. Next question here. Is there a cure for BPH or is this a lifelong condition?
There's no cure. Yeah, I was just listening to a podcast today, and they were talking about like, hey, what's in the future? So because they were talking about, what are some of the biggest advances in BPH, and there was all the talk about the minimally invasive treatments like the Resume procedure and the UroLift procedure, and they were saying, well, what's the future hold? And one of the panelists was saying, I would like more research into what causes it, so someday we can do something to prevent it and not just treat it. But the answer is no, there is no cure for BPH. It's a lifelong thing. It's basically your genetics. Because of your genetics, your prostate has enlarged and caused some urinary symptoms. Currently, there's no cure. There's treatments, medications, minimally invasive procedures or surgery, depending on each patient, but currently there's no cure.
Alrighty. Next question here. If you developed these BPH symptoms, prostate enlargement symptoms only after RX for prostate cancer, what is your best course of treatment? So I believe they're taking a prescription for prostate cancer.
Say that one more time. I guess it ain't complete.
Yeah, so this person's saying they developed symptoms of, and they didn't specify the symptoms, I guess, but I'm guessing discomfort, frequent urination of some sort after taking an RX for prostate cancer.
Okay.
They want your best course of treatment is.
Yeah, I guess it's a little tough question to answer, not knowing the history. And so, depending on the treatment they had for the prostate cancer, depending on the medicines that they may be taking for the prostate cancer. Again, prostate cancer, like I said in the presentation earlier, can sometimes show similar symptoms of BPH as the prostate cancer. If it's a kind of a more advanced one, if it squeezes on that urinary tube like an enlarged prostate does, it can cause some urinary symptoms. Usually a medication to treat prostate cancer is not going to cause urinary symptoms. If anything, it's going to help. If it's a prescription, oftentimes it'll shrink the prostate. But again, without knowing the specific treatment or the specific prescription, it's hard to answer that completely.
Ready. Next question here. Are there any over-the-counter treatments for BPH that we didn't cover in the slides?
So there's a bunch of different over-the-counter nutritional supplements. The most common, pretty much any supplement that for prostate BPH has some sort of saw palmetto. When it comes to saw palmetto, there's been several studies that have been done on it. Some have showed some improvement in the urinary symptoms. Some have not shown very good improvement. So it's kind of mixed data out there. So it's hard to give an overall consensus. And so that's why I don't promote it, but I also don't poo-poo it. So what I tell patients is that, hey, if you want to try it, it's not going to hurt anything. The risk is pretty low. There'll be a placebo effect initially. And then if you feel like it's providing some relief, it's okay to continue it. But if you feel like it's not really making much difference, you don't need to continue to spend your money on it. But each person can try it. Like I said, that's that big portion of men. Men don't like to go to the doctor, but like I was saying earlier, they watch TV at night, they see a commercial, they go online, they order this, and they kind of struggle along on that for years. And if it works, okay, but don't put off seeking medical attention at the expense of taking a supplement that's not working for years. And again, I take supplements myself. I don't take saw palmetto. Maybe someday I might, but currently, so I'm okay with supplements, but saw palmetto, the data is mixed, I would say.
Alrighty. Next question here. This question is from the chat. So this person wants to know, what is the name of the app you mentioned that can gauge your urinary flow strength?
Oh, that's a good question. I don't know the exact name. I would have to look it up. And so our practice is currently not using it. It's something that I actually just on the I was at an outreach clinic today. On my way home, I called up one of my friends whose practice is currently using it. It was getting his input on it. So I don't know the name of the app yet, but
We
maybe in the
so
future.
at menMD, we actually just released a new product on our shop today. It's called the Men's Diary Pod. This is an at-home bladder test. So this is a device that comes home with you. You'll urinate into it, and it also hooks up to your phone via Bluetooth. So kind of similar function to what Dr. Schulte was describing here, but we have our own version available on the shop as of today. So fresh item available. If you'd like to go check that out, go over to menMD.com and navigate to the shop page. But moving right along, next question here is going to be some procedure-specific questions. So with Resume, how soon can I expect to see improvement in my symptoms?
Yeah, so what I tell patients is that Resume shrinks the prostate. When you treat the prostate with the steam or the water vapor, again, long-term, it's going to shrink it. Before it shrinks it, it's going to cause it to swell. And so both Resume and Urolift often will require a catheter for a few days because there's some swelling. And then as that swelling goes down, again, the first few days to a week or two, everyone's a little different. You'll see some increased urgency, increased frequency, some irritation with urination. Usually after a few days, a week or two, that irritation is going to go away. And then I tell patients at 1 month, we're going to see some good improvement in the symptoms. 2 months, we'll see better improvement in symptoms. 3 months, we see really good improvement. And so kind of 3 months, 3 to 6 months is when you see maximum improvement. You start to see some good improvement in about 1 month. And like I was saying earlier, that line, I always tell patients 3 days afterwards, you'll be me, why did I do this? It's irritated, things are a little worse. 3 months afterwards, you'll be saying, why didn't I do this earlier? Because by and large, patients have a good response. But I always prepare them that you're going to have that irritation for those first few days, to a week or longer. After the catheter comes out, you can go back to normal activity, whatever you want to do. But usually the catheter will stay in for, 2 to 3 to 4 days, depending on the size of the prostate and the number of treatments.
Alrighty. Next question here. Is Resume treatment as effective as the green light laser treatment?
In the properly selected patient. So the patient that is best for the Resume procedure is a patient with a mild to moderately enlarged prostate. So again, a normal size prostate, which is the size of a walnut, what we call 20 to 25 grams. Resume procedure works best in patients that have about a 30 to 80 gram prostate. Those are the ones that with a mild to moderate enlargement works very well in those particular patients. Patients with like 100 gram prostate or bigger, can we do a Resume? Yes. Is it going to be effective? No. So like I was talking about before, I want to do the least invasive, most effective procedure. So I can do a Resume procedure in a 100 gram prostate, and it's the least invasive, but it's not overly effective. I can do a green light laser in a 40 gram prostate, and it's effective, but it's overly invasive. And so the answer to is it as effective as the green light laser in prostates that are 30 to 80 grams? Yes, it is just as effective and then a lot less invasive. For the prostates that are really big, over 100 grams, it's not going to be overly effective and it's not going to be recommended. Green light laser works very well for those prostates that are 90 grams, 100 grams or larger. And that's why it's important to talk with your doctor and see what's the best option for you. It's not, again, there's not a one size fits all. And so if anybody ever tells you like, oh, this is the best treatment for everyone, that's not truthful. We want to find the best option for each individual patient.
Alrighty. So moving right along, got a couple of urinary questions here. So the first one is, I have a problem with leakage of urine and have to wear a pad. However, I don't like wearing the pad. What else can be done about this?
Yeah, so if you have urinary leakage, it probably we would recommend some further testing to see what's the cause of that urinary leakage. Is there overactive bladder in addition to enlarged prostate? If there's not any enlarged prostate and it's strictly overactive bladder, there's a different set of medications and minimally invasive treatments that can be done for overactive bladder that I didn't cover at all. But if it's enlarged prostate that has caused overactive bladder, usually we need to do something to treat the enlarged prostate first, because that's the source of it, and then can also address the overactive bladder, the urgency and the urge incontinence as well. So I think first steps would be to kind of get to the, like I was saying before, one, make sure it's not any worrisome issues. Two, get to the bottom of what exactly is causing it. Is it just BPH and OAB, or is it overactive bladder? And then three, come up with a plan, to figure out what's going to be the best long-term, least invasive option for you.
Alrighty. Next urinary question here. If any, what are the best over-the-counter supplements or medicine for frequent urination?
Yeah, I mean, again, they're all pretty similar. Anything that they're all going to have saw palmetto, and so it's not like one is any better than the other and stuff. And so, I basically, I tell patients that again, try it, and if you feel like it works, that's fine. If it doesn't work, don't continue to spend your money and explore some other options and stuff. But it's not like they're all just a version of different saw palmetto supplements, but it's not like there's one that's significantly better than other.
Alrighty. Next question here. This question is from the chat. This person would like to know if there will be any regrowth in the prostate following a resume procedure.
There can be. Just with any procedure, resume, urolift, green light, TURP, there can always be some regrowth of prostate. And so like I talked about before, the retreatment rate for resume procedure at 4 years is about 4.4%. So over 95% of patients will not need any additional therapy. And it's all about proper patient selection, like I talked about earlier. If you try to treat a 100-gram prostate with resume, it's not going to last long. It'll provide some relief, but it's not going to last long. But if you treat a 50-gram prostate with resume, you can provide some, durable treatment. And so resume has not been around for 25 years like TURP, so we don't have 25-year data, but the early data shows pretty long, reliable treatment. And it's all about each patient's different. So figure out what is important to each patient. And so some patients would be like, if let's say you have a 70-gram prostate, you can do a resume, you can do a green light. And I just tell patients the advantages and disadvantages of both. The resume is much less invasive, and you're probably going to provide some relief. Is there a chance you would need retreatment down the road? Possibly. We don't know for sure. The green light therapy for those big prostates will provide, probably some better immediate relief, but it's more invasive. And so some patients, hey, give me the least invasive. I want the least downtime off work, provide some durable relief. And some patients are like, I don't care, be invasive. I want you to remove as much tissue as possible, so it's going to last as long as possible as well. So each patient, I could have the exact same patient set of circumstance and present them with both options, and I have a discussion with them of what's important to them and what's going to be best for them. So,
alrighty, we are nearing the end of our event here, so we have time for about 1 or 2 more questions. So, next question here: I'm up every 4 hours at night to urinate. Should I assess my prostate now?
Yeah, I mean, if you're getting up every 4 hours at night, I definitely would recommend seeing your doctor and talking about it, to see. Nighttime urination is a complex problem. I tell patients sometimes it is due to enlarged prostate. Sometimes it is due to urinary issues from enlarged prostate. Sometimes it's due to poor sleep patterns. Maybe you have obstructive sleep apnea. Maybe it's a sleep problem, and hey, I'm getting up at nighttime and I wake up, and because I'm up, then I'm cognizant, and then I'll go to the bathroom. But I didn't wake up because I had to go to the bathroom. I woke up for another reason, and then I went to the bathroom. So, but if you're getting up at every 4 hours, even if it's not a urinary issue, you should see your doctor, because maybe obstructive sleep apnea could be a problem as well. So I definitely would recommend, something to talk with your doctor about.
Alrighty, and this will be our concluding question, bit of a summary. What are the ways in which you can definitively assess the mass of the prostate?
So I tell patients, prostate exam with my finger. I'm going to make sure I don't feel any hard nodules, and I'll get a general sense of how enlarged or a general sense of whether it's enlarged or not. It's not accurate at all to tell me, hey, is this a 30-gram prostate or an 80-gram prostate? So in order to determine, is a patient a candidate for medical therapy, resume, green light, we need some sort of imaging. Some patients, if they've had a prior CT, we can get imaging off that. A lot of times we'll do an ultrasound of the prostate. An ultrasound of the prostate is done just like a prostate exam, and we can get some exact measurements of the prostate. And that is important. And that was added to the American Urologic Association guidelines within the last several years, that it's recommended to have some form of imaging to determine the size of the prostate, to help determine what's the best treatment option for that patient.
If you'd like to learn more about BPH, you can visit menMD.com and head to the Resource Center. You can view this page to view instructionals, videos, guides, expert articles, and more. If you'd like to compare any of the treatment options we covered during tonight's event, you can do this by going to menMD.com, navigating to the BPH condition page, scrolling down to the treatments, and selecting up to 3 of these BPH treatments to compare. You can also call menMD at 857-233-5837 or log into the password-protected portal to schedule an appointment with a menMD personal health assistant. If you'd like to learn more about the green light laser therapy or the Resume treatment mentioned tonight, you can visit resume.com. That is REZUM.com.